Welcome to AETCM, the emergency medicine channel. Shall I start, sir?
Yes.
65-year-old female patient brought to ER with complaints of generalized tiredness for the past 2 weeks, associated with complaints of vomiting, abdominal pain, and loose stools for the past 2-3 days with altered sensorium since today morning. On initial 10-second assessment, patient is drowsy and
Once more. What is that?
65-year-old female patient brought to ER with complaints of generalized tiredness for the past 2 weeks with a history of abdominal pain, vomiting and loose stools for 2-3 days and altered sensorium since today morning.
Okay.
On initial 10-second assessment,
Basically CNS manifestations, GI manifestations, and generalized fatigue. Okay.
On initial 10-second assessment, patient is drowsy and confused, airways patent, no pooling of secretions, no gargling, breathing, respiratory rate is 20 per minute with a saturation of 96% in room air. Chest is air entry bilaterally equal with occasional wheeze. Coming to circulation, BP is 80-50 mm of Hg with pulse rate of 120 per minute. At that time, we connected to the cardiac monitor, and also we put 2 large IV bore cannula and started on IV fluids.
But wheeze was there, no? Wheeze should
Occasional
have given
wheeze is there.
occasional wheeze.
Wheeze is there.
So the issue is in B and
C. Coming to disability, GCS is E3V4M6 with pupil bilaterally equal and reactive, and GRBS is 48 milligram per dl. So that at that time...
GCS is full?
No sir, E3V4M6, 13 by 15.
The initial complaint had some...
Altered sensorium. Okay. And GRBS is 48. So we corrected at that time with 25% dextrose.
Okay. So it's because of hypoglycemia. The sensorium drop could be because of hypoglycemia.
And exposure, the patient at that point is febrile, skin.
And after correction, did it improve? Did the GCS improve?
Yes, we reassessed the patient. Patient GCS is slightly improved, like E3V5M6.
Then exposure.
And exposure, patient is febrile. There is skin. There is no hyperpigmentation, no our palmar creases, but dry mucosa is there, and poor skin turgor is also there.
Why did you check all these things in primary survey?
Because the patient presented with vomiting and loose stools, we check for any signs of dehydration. Multiple episodes of loose stools and vomiting for the past 2-3 days with altered
discoloration you mentioned in... Why did you mention that?
We can also, in the history wise, there is steroid history intake is also there. But initially...
but in primary survey, because we haven't taken the history so far, right?
We only have to check for the dehydration.
It will seem as though you are totally biased towards some other diagnosis which is already in your mind. Okay. So in my mind, it is like some altered sensorium, some GI symptoms, some generalized tiredness because of hypoglycemia, right? And some wheeze is also there.
Occasional wheeze is there. So initially, after the primary, initial arrival symptoms with the initial 10-second assessment, we reached at a diagnosis of acute more possibly acute gastroenteritis with hypoglycemia and dehydration. And we proceeded with primary adjuncts, which is CBC-CRP, which shows total counts of 15,200 with platelet count of 210,000 with HB 12.8 and CRP 6.8 milligram per dl. 6.8, and in VBG, the pH is 7.38 with bicarb 24, PCO2 is 30, with serum sodium is 118, and potassium is 4.2.
So then hyponatremia can also be the cause of decreased drowsiness, decreased sensorium. Potassium?
Potassium is 4.2 with lactate 2.8.
Lactate 2.8. Okay.
And we took one ECG also, we show sinus tachycardia.
Why did you take ECG here?
The patient also has altered sensorium with abdominal symptoms, so elderly patient with abdominal symptoms.
You wanted to rule out ACS?
ACS also, just. Tachycardia is also there, BP is also in the lower side.
So this could be is it sepsis? Could it be a sepsis with septic encephalopathy?
Sir, possibility is there, but creat and everything is all
sepsis
normal.
with septic encephalopathy. Does it meet
On
criteria
calculating SOFA score, the platelet counts are normal, bilirubin is normal, creat values is also normal, in the normal range.
But a suspected source of
One infection is there, 15,000 counts is
there.
With CRP 6.8.
Like GCS drop is there.
GCS drop.
Pulse rate is high. Respiratory rate is high.
It's high.
With these. So that is also a possibility. So septic encephalopathy is one possibility. Hyponatremia is one possibility. Hypoglycemia is a possibility. All right. Okay. Or LRTI with V's you told.
Occasional V's is there.
There could be an LRTI with so focus could be in the lungs also.
So no symptoms as such, but and coming to the secondary survey, the patient is not
So at the
allergic.
end of your primary survey, these are your DDs.
And coming to secondary, the patient is not allergic to any medications. On medical history, patient is a non-case of bronchial asthma and on inhalers and also low dose oral steroids because of severe persistent bronchial asthma, and also newly diagnosed diabetes. Presented to the ER with complaints.
Diabetes because of steroids.
1 month back, she diagnosed with diabetes.
Okay, type 2 diabetes. It's not hyperglycemia because of steroids.
More possibly due to chronic intake of steroids.
Any idea about the HbA1c?
HbA1c is 9.4.
Okay, then it's a chronic thing.
thing.
It's not a steroid related. Okay.
Patient is on oral steroids for the past more than 1 year.
1 year.
With complaints of generalized weakness, loss of appetite and nausea, and this progressed to repeated vomiting, diffuse abdominal pain followed by confusion. And there is a history of fever for the past 2 days also. There is no history of chest pain, palpitation.
So right now you are at the end of the thing, chronic steroid intake with associated all these non-specific symptoms points towards what? What could be the possibility? Steroid.
The patient is on oral steroids for a chronic period, and there is a history of fever for the past 2 days. So acute infection maybe lead to the patient to an adrenal insufficiency and adrenal crisis.
Yeah. Because in adrenal insufficiency, only like even either it's primary or secondary
adrenal
these kind of non-specific complaints, generalized tiredness, all these GI symptoms, all these neurological symptoms, all these things will precipitate. And on top of that, if there is some skin discoloration, here you can mention about skin discoloration, things like that, because you want to know whether it's because of a primary adrenal insufficiency, which is also called as
Addison.
Addisonian crisis. All right. Because in secondary you won't get all these skin discolorations. Okay.
There is no history of chest pain, palpitation or sweating, no history of constipation, no history of
palpitation was not, but sinus tachy was there.
No history of trauma, follow seizure, no history of toxic injection.
RS you don't mean, you go according to that OD para thing, no? Onset, duration, intensity, progression, like that. No
history of cough. No, patient is already non-case of bronchial asthma, so there is only occasional wheeze, but there is no history of acute onset of cough or expectoration. Nothing was there, and no history of urinary symptoms. And patient was on long-term steroids. And on systemic examination.
No, the thing is you have skipped considerable amount of things in your history. Because you'll have to go systematically. Right now we have just mentioned the major points which points your diagnosis towards an this thing, adrenal insufficiency. You have mentioned something in CNS, GIT, this few points which points towards only a single diagnosis. Okay, so you are just leaving all the other diagnosis and primarily you are trying to focus only on one diagnosis. So that shouldn't be the way you should be approaching in an ER. You should have a broader outlook. So one by one you will have to dissect, go deeper inside. Then only this adrenal insufficiency, these are all like the rarest of the rare diagnoses. Primary adrenal insufficiency should be a last diagnosis. Okay, so other things will have to be ruled out. System wise you will have to assess. Go according to that OD para, whatever the complaint is, onset, duration, intensity, progression, previous episodes, aggravating relieving factor, associated symptoms, all these things. Then associated symptoms, you go according to system wise. CVS, what all things. Any system complaint pertaining to CVS, any complaint pertaining to RS, any complaint pertaining to GIT, genitourinary, musculoskeletal, CNS, like that. Then miscellaneous, any fever, any weight loss, any dermatological problems, like that. One by one, any urine or any problem in urine or urination, one by one you'll have to go deeper. Because ultimately your diagnosis may change. Okay, given what you have told, it's adrenal insufficiency. Okay, so that is how you'll have to go. When you go, you can't straight away jump to the systemic examination before elaborating on history.
And on systemic examination, chest is.
And then what all drugs he was on? Drug history is important. What steroid he was on?
Deflexacort 6 mg is.
What dosage?
6 mg OD.
What other drugs he was on?
On oral inhalers. I mean inhalers only she is using. Other than that.
Okay. Is she on any other recreational drugs?
Okay.
Any cocaine, things like that? Something, I think more is there or not? And personal history, family history, all these things you'll have to mention. Okay. You don't go to those aspects.
Usually we didn't take that personal history and all. Just the sleep, appetite and all we will ask. And systemic examination, chest is air entry bilaterally equal with occasional wheeze.
General examination, no?
General examination, there is no pallor, icterus, clubbing.
Conscious, alert, cooperative.
Sir, patient initially was drowsy and after correction of hypoglycemia, patient is little bit better. And no pallor, no icterus, no cyanosis, clubbing or lymphadenopathy. And in systemic examination, chest air entry bilateral equal with occasional wheeze. And in CV assessment as to heard with no murmurs. Abdomen is soft with diffuse mild tenderness is there. With
Where?
Sir, mild diffuse tenderness is there. No focal tenderness is not there. No organomegaly. And in CNS, initially the patient is
because
drowsy
an adrenal insufficiency or maybe some abdominal pain will also be, primary.
And in CNS, patient is initially drowsy and confused. Later, after correction, she became better and no focal neurological deficits as such. So in this case, we initially supported the patient. We first corrected the hypoglycemia. Then we started the patient on IV fluids also.
You stabilized all the vital signs. The primary survey, at the end of primary survey, you addressed all major concerns. Yeah.
And after that, the patient is also on low dose steroids for more than 1 year. Because of the current infective status, there is chance for adrenal crisis. So we give one IV injection hydrocortisone 100 mg IV start also.
Okay. So it's an assumption. You thought it could be an adrenal insufficiency and you gave considering the history and all those things.
Before that, we sent the serum cortisol levels, ACTH levels and all.
Yeah,
and all
that is
the
important. Before giving steroids, you give ACTH cortisol. What is the purpose of taking that?
So serum cortisol and ACTH levels. Serum cortisol, if it is less than 18 microgram per dl, it will. If it is more than, it will rule out the adrenal insufficiency. If it is less than, then we have to check for the ACTH levels also to differentiate.
It basically helps. It's not for the emergency physician. It basically helps in workup of this case. Basically for physicians or endocrinologists, if they want to work up, if they want to find out what the primary cause could be. Is it primary or secondary? Then it becomes helpful. Because in ER, for an ER physician, these things doesn't matter much. Okay. So the final diagnosis is based on what you send initially. Because once you give the steroid and
the values will be
values will change.
So we come to a provisional diagnosis of adrenal crisis, more possibly due to secondary adrenal insufficiency, since the patient is on chronic oral steroid intake, and that is precipitated by infection. Okay. So coming into the discussion
that antibiotics were given?
We started on empirical IV antibiotics also.
So we gave steroids, fluids, IV antibiotics.
And also we sent Walker for
addressing this thing, GIT
symptoms also.
So what antibiotic?
We started on, since the CRP is lower side, we started on ceftriaxone initially.
You considered it as gastroenteritis? Loose stools also.
Loose stools also.
So
we
considering that you give sulfite.
separate.
Okay.
And coming into the discussion of this adrenal crisis and adrenal insufficiency, the adrenal gland is divided into cortex and medulla. Cortex, the embryological origin is mesoderm, and medulla is neural crust cells. So from an adrenal gland, from the cortex, there is it can be differentiated into zona glomerulosa, zona fasciculata, and zona reticularis. So in case of zona glomerulosa, it releases mineralocorticoids, aldosterone, and zona fasciculata cortisol, and zona reticularis is androgens. Medulla will release the catecholamines, that adrenaline, noradrenaline, and dopamine. So in case of primary adrenal insufficiency, otherwise known as Addison's, this is due to the intrinsic adrenal gland dysfunction. So that will result in the decrease of all the hormones which is released from cortisol, aldosterone, and also gonadotrophin. And 90%.
So basically, there is a hypothalamus, there is a pituitary, there is an adrenal gland. So all these things, hypothalamus controls the pituitary, pituitary controls the adrenal gland.
From the hypothalamus, corticotropin releasing hormone will come.
Yeah.
From the pituitary, there will be ACTH, adrenocorticotropic releasing hormone.
Cortisol releasing hormone from hypothalamus, ACTH from pituitary, and adrenocorticotropic hormone. It will act on the adrenal gland. Adrenal gland has got cortex and medulla. And then again, it's subdivided into glomerula, fasciculata, reticularis. Okay, and each part will release each kind of this thing.
Hormone. And 90% of the gland must be destroyed for the clinical adrenal insufficiency. And in case of secondary adrenal insufficiency, that
is a very rare diagnosis. Rarest of the last diagnosis. Okay.
And secondary adrenal insufficiency is due to the hypothalamic pituitary dysfunction, that axis dysfunction with the failure to secrete the corticotropin releasing hormone. That is,
so there could be some problem in the hypothalamus, could be some problem in the pituitary. Okay.
That will lead to the failure of
maybe some tumor also.
Maybe tumor. Lead to the failure of secretion of the corticotropin releasing hormone or ACTH, that results in the cortisol deficiency alone. And in case of adrenal crisis,
in primary adrenal insufficiency, ACTH as well as this thing will be low. But
ACTH will be high, sir.
Which one?
In primary adrenal insufficiency.
Yeah.
Because decrease in the amount of the hormone, so that it will give a positive feedback, and ACTH will be high. Right. In adrenal crisis, the life-threatening exacerbation of this adrenal insufficiency because of the increased demand, and the gland is failed to produce the hormone. So, what are while discussing about the functions of the aldosterone and cortisol will help facilitate the stress response by affecting the heart and vascular bed, and also it helps in the electrolyte balance, water excretion, and also the potentiation of the catecholamine release also, because it induces one PNMT, that is phenylethylamine N-methyl transferase in medulla, that enzyme which converts the norepinephrine to epinephrine. And also for the control of water distribution, and it also affects the fat, protein, and carbohydrate metabolism by stimulating the glycogenolysis and neogluconeogenesis, and it's also involved in the immunological and inflammatory responses. And it's also promote the growth and development and interfere with the GI tract mucosa maintenance in case of cortisol. In case of aldosterone secretion, that is mainly controlled primarily by the renin-angiotensin system, renin-angiotensin-aldosterone system, and also the serum potassium concentration. So it controls the aldosterone in response to changes in volume and sodium intake. So if it is there hyperkalemia, it will influence the adrenal cortex, and it will lead to increase in the aldosterone secretion, and it maintains the sodium potassium plasma concentration, and it also regulates the extracellular volume. And in case of gonadotropin, that is androgen, estrogen, testosterone, and also dihydroepiandrosterone and dihydroepiandrosterone sulfate, which helps in women for the both axillary and pubic hair growth, and also for the libido.
Basically, it causes all fluid electrolyte imbalances in the body. Disruption of this thing will disrupt all these things.
And also the gluconeogenesis and glycogenesis. It also leads to hypoglycemia. So when we discuss about the primary adrenal insufficiency, the main causes is autoimmune, that is either isolated or associated with polyglandular insufficiency, and also in case of adrenal hemorrhage, thrombosis, necrosis by the meningococcal, and sepsis, coagulation disorders, or overwhelming sepsis, which is known as Waterhouse-Friderichsen syndrome. And also the drugs which inhibit the adrenal enzymes, that is etomidate, aminoglutathione, and mitotin and ketoconazole. These are the drugs. And the most common in India, the infections like TB, tuberculosis, fungal or bacterial sepsis, HIV and all, and infiltrative diseases like sarcoidosis, hemochromatosis, amyloidosis. And in case of surgery, that is bilateral adrenalectomy, and hereditary conditions like adrenal hypoplasia and all. And secondary insufficiency mainly due to the inhibition of the HPA axis, so that cause is prolonged glucocorticoid therapy, pituitary necrosis or bleeding followed by postpartum Sheehan syndrome. And also in case of brain tumor, pituitary or hypothalamic tumor, local invasion in case of craniopharyngioma, and also in case of pituitary irradiation surgery or head trauma, and also in CNS infections and all. And
it could be infection, it could be a tumor, it could be because of a trauma,
brain surgery and
brain surgery, or steroid, long steroid intake.
And in case of primary adrenal insufficiency, the clinical
also called as Addison crisis.
There will be symptoms like hypotension associated with circulatory failure or shock, which is known as Addisonian crisis, anorexia, nausea, vomiting, diarrhea, abdominal pain. And the differentiating feature in primary and secondary, it is hyperpigmentation because of increase in ACTH, and also the hyperkalemia and volume depletion.
Where is hyperpigmentation seen?
In case of primary, there will be increase in ACTH production, so there will be hyperpigmentation. And also we can see hyperkalemia and volume depletion more in case of primary because of a deficiency in aldosterone. Secondary cases, there is more deficiency in cortisol. So this hyperkalemia and metabolic acidosis and this hyperpigmentation won't be there in secondary. Secondary mainly due to the cortisol deficiency, so there will be weight loss, lethargy, weakness, mental status changes, GI symptoms, and if there are any gonadocorticoid deficiency, there will be decreased axillary or pubic hair and decreased libido will be there. And we can send for the investigations like CBC, complete blood count, serum electrolytes, calcium, serum cortisol levels. We can send LFT, liver function test, urine analysis, chest X-ray can be we can take in part of to rule out primary, secondary, and the causes of adrenal insufficiency. Either there is any tuberculosis, bacterial infections, pneumonia. We can do CT abdomen to look for the adrenal gland, any hemorrhage or infarction. We can
this is basically for a workup.
Okay.
Not in an ER. After admission only you can do all those things. You don't have that much of a time to evaluate each and everything in other things. You just give the suspected diagnosis, give the initial dose of ACTH and cortisol and all those things, take samples and then give steroids.
Admit the patient twice. And head and CT also can be taken to rule out the secondary adrenal insufficiency causes. So in the primary management, initially we corrected the hypoglycemia and we started the patient on fluids, 0.9% saline, 30 ml per kg initial bolus.
Because in the investigations and all, you are not anyway going to do anything.
Yeah.
Even if you do all these things, you can just find out a final treatment for the definitive diagnosis by the endocrinologist or physician. Okay.
So in this case, when we deal with the adrenal crisis, we have to start the treatment immediately, and the prognosis is related to the rapidity of this treatment onset. So initially in this patient we corrected the hypoglycemia, and after that we started on IV fluids for hypotension. We can use either dextrose or saline. If the patient is hypoglycemic, we can use dextrose also. And if we have a diagnosis of adrenal insufficiency, we can give steroids, that is injection hydrocortisone, 100 mg IV bolus can be given. And if there is no IV access, we can give IM dose also, followed by IV infusion of 200 mg over 24 hours, or we can give 100 mg every 6th hourly. Or other we can give dexamethasone 4 mg bolus. Alternative. Drugs is dexamethasone 4 mg bolus. Then we have to add fludrocortisone also 100 mcg per day, because dexamethasone, fludrocortisone 100 mcg. Since the dexamethasone doesn't have any mineralocorticoid action, less mineralocorticoid action. And also we have to give the supportive care, airway, breathing, circulation, and we have to give the bolus. If the patient again went into hypoglycemia, we have to check for that and have to give glucose, and we also have to correct any metabolic abnormalities like hyperkalemia, hyponatremia, hypercalcemia, and we have to consider vasopressors if the patient is unresponsive to the fluid, and we have to determine the underlying cause and have to treat. In this patient, there is gastroenteritis picture is there with the kind of sepsis picture, so we have to start on antibiotics, IV antibiotics and all, and we can admit the patient to ICU and continue the monitoring. And we also have to know the steroid equivalence doses, like hydrocortisone 20 mg is equivalent to prednisolone or prednisolone of 5 mg and methylprednisolone or 4 mg, and dexa of 0.75 mg or methazone is 0.6 mg. And there is also term like tertiary adrenal insufficiency in case of impaired hypothalamic release of cortico-releasing hormone, which result in the decreased production of ACTH by pituitary. That is tertiary adrenal insufficiency.
In MRCM and all, there is one question where, like, usually in UK and all, people having primary adrenal Addison insufficiency will have a bracelet and all. So that is one thing to identify these kind of people. So if they come and you find a bracelet just to identify these people, then you can.
So
you don't need to do
you
can, because you already itself you know that this guy is having a problem. Then you can initiate on
steroids.
But here in India and all, it's people don't wear such things, so you're confused whether he's having this thing or that thing. It's useful. Anything? Okay, thank you.